Hi, I'm Teresa O'Callaghan. You've heard my name mentioned a couple of times this morning as I'm back down lower in my chair each time. And I get the privilege of talking to you after lunch. So they stick the administrator after lunch. Thank you. Okay, I have 10 minutes to speak to you about my experience as the so-called administrator in healthcare and decision maker. But I want to kick off by saying, is that better? Yeah. That my journey began with Sonia. And I'll be totally honest and transparent here. I heard about Sonia and I ducked for cover. I did. I dodged her for months because I heard a rumor that Sonia was coming and she wanted money for a program and that she wanted to do something new at the site. So she finally pinned me down. There was food involved and she did a presentation. So I'll talk about that more as we go on, but I just want to be honest. I did avoid Sonia. So this is probably what you think administrators think, right? The standard, what's in it for me, this is what our priorities are. And it's been alluded to earlier today about what we do want or what we don't want. And the first thing you'll see, I've highlighted a few things there. Financial stewardship, that's a fancy way of saying money. So the budget. Quality and safety is in a lower font. It's one of our priorities though. Capital equipment and infrastructure management, health human resource planning, those are all money. Provider experience, patient experience. So the three lower font items, they're in there and they're definitely considerations as a decision maker or a health administrator, but you can see where typically we are perceived to be sitting. That's not necessarily true. So how do you get my attention? What matters to me? Top of mind is patient experience. And this is how Sonia hooked me, because she brought Larry. Larry is her secret weapon. Because how can you not be moved when you hear Larry and his experience? So for anyone else out there who is seeking to advance this agenda, take a patient partner, because they're the ones that will convince anybody. Next for me is provider experience. It's hugely important to make the work satisfying and meaningful for the people that are delivering the care, that are doing the work. Quality and safety go hand in glove with the two above as well. So those are my three top priorities whenever anybody comes to me. However, in lowercase font, we've got the other three things, which are all money, which is why the first thing you do is don't come to an administrator or a decision maker asking for money, because like me, we will avoid you. So how do you get my attention? There are a few different ways you can do it, and I think some of these billboards are fascinating. Sonia didn't do that, she brought Larry. So how really get my attention? The items I've really talked to you about. You've got to appeal to my sense of wanting to be able to influence patient and provider experience while adhering to a quality and safety agenda. It's got to also be something realistic within my ability to staff it. That's your HHR planning piece. I've got to be able to afford it, but that doesn't mean it has to be a line item in my budget already. It means that I have an opportunity to be creative. I have budget. When Sonia came to me, I was a director and I had certain program areas. I had a finite budget. And as Hilary alluded to earlier, you've got your costs and your budgets established year over year over year. And our primary focus is trying to stay within budget, or at least to keep the variance as small as we possibly can. So how do you do that, but still get creative? Well, there are often FTEs, that's your full-time equivalencies for your staff, that you're not actually fully using. So there's snippets of budget that you can pull together from here, there, and everywhere, and you can put together enough, usually, to fund a position, if you're motivated to do so. I was actually really lucky because I had a position that was being underutilized, and we were able to repurpose it. We had to go through the ministry because it was a nurse practitioner role at the time, but we got approval. And again, thanks also to Sonia's creative writing, because she was very, very supportive in formulating the rationale to make the argument to get the NP repurposed. And we were able to get the 0.6 FTE for an FLS coordinator. And the rest pretty much is history. As far as that, you've heard from Sonia how that was put together. So again, as I said to you, if someone is coming to you as an administrator or as my role as an administrator, what was important to me was the patient partner. So Larry with Sonia, hearing about the patient experience. I also had a very compelling argument made to me about the health economics, and you've heard Hilary speak to that again this morning as well. The cost benefits, you're not going to make any money off of this. It's not a revenue generating proposition. It is a cost saving proposition over the long term. And that's the other thing, is to not think in the moment. You have to think about what the future benefits, not just to the system are, but also the people. So one of the other compelling factors for me was thinking about the lives that are impacted. If you think about someone who has a fragility fracture that is missed, and we don't take this opportunity to implement an FLS, which we've heard loud and clear is the only solution to close this care gap, then think about all those people who have life experiences like of which Larry has shared with us. And I thought in terms also of the hip fractures, because Sonia was very smart in focusing on hip fractures and bed days in hospital. If we could prevent a percentage of those hip fractures, we could keep a percentage of people out of those beds, keep the operating costs down, not have people end up in long-term care assisted living facilities, which are also costs to the system. And if we can free up all those dollars, just think what else we can do in order to improve quality outcomes for patients. So it was a win-win. It was also a no-brainer the way it was presented to me. So I have to say it was a really easy decision to make that coincided with opportunistic funding. I got that little picture up there because persistence, like I said, Sonia, I ducked her, she didn't give up. So you've already seen this slide this morning. This was the Mission Impossible team that made it possible and laid the groundwork at Peace Arch, and for the work that you've heard about that has followed since then. So the fracture liaison service, it can be done. You can do it too. And I know that I think there is another colleague, a director in the room, Karen Barkley, I'm going to call you out, who is their operations director at Richmond Hospital as well. And you have done it too. Would you mind sharing a few minutes with the group?
Sure, I'll be happy to. Hear me okay?
Feel free to come up here. Share the pain.
It's about peer pressure. Positive peer pressure.
There you go.
I think, you already introduced the idea that was the decision point for us in Richmond as well, which was the completely compelling story that was brought to us. And when I say us, I think that's the second key point that I want to make, was the fact that Leo and his team brought the story, as well as Dr. Cranney, to a table of people who had the ability to make a decision, to be opportunistic with funding, and to put some attention to this very compelling need. And if you're not in front of the right people, you can tell your story again and again, but you're not going to get that pickup from operations. So for us in Richmond, it was really key that the team was actually able to get to our senior leadership table on the agenda in front of, I think instrumentally in front of our community vice president, because she had the view of the whole system. And much like Teresa has a systems view, Yasmin Jetta in Richmond was looking at her portfolio, which includes long-term care, which includes home support and home care and mental health. And I think about your story. So she heard this compelling description and was able to envision how this was impacting widely across our whole population, not just surgical beds. And it was actually under her executive sponsorship that we took the business case forward. So if I give you one tip from my experience, I would just say, do your homework and ask all those questions in your settings to find out who the decision makers are and try to get in front of the people who can actually make it happen. So, yeah.
Beautifully said.
Thank you
so much. Do you want me to take questions? After lunch, you're all lulled into. Oh, yes.
It may be more rhetorical than not, and probably for people who are decision makers. So I read the tipping point by Malcolm Gladwell. So that got me thinking. We're 10 years now after. So it's been 10 years since FLS programs have been shown in multiple clinical trials.
to improve patient outcomes and save costs pretty much worldwide in every setting they've been used. And 10 years later, it's a bottom-up approach that we're still doing. So individual clinicians at individual hospitals are approaching individual administrators at individual hospitals and starting individual programs. What's the tipping point where it changes to top-down? Because it's effective and it's evidence-based and it's been demonstrated. So like, what's the tipping point? Are we going to continue to have seedling programs until it permeates the country, or is this something that should be starting to be from a top down, and what is the tipping point for that, or what might it be? So my opinion, so personal opinion, not Fraser Health opinion, my personal opinion is I'm really grateful for the fact that we've got ministry people in the room. I think we really need to be able to influence our political partners to have them recognize that this is a silent pandemic. It really is, and it deserves the attention that we've given to things like cardiac conditions in the past. So I'm a convert, clearly. And I do think that the more we talk about this, the more it's surfaced, the more seedlings that sprout. So grassroots up is fantastic. But getting in front of, as Karen alluded to, the right decision makers in the health authorities and at the facilities is also a good start. I got to confess, when it was my opportunity, I didn't ask permission. I didn't go to a VP. I didn't go to my executive director at the time. I just thought, wow, and we did it. And I think there's opportunity to do that as well. So as much as, yes, we need to get in front of the right layers, there's also opportunities to just do it. So that would be my advice. Just keep doing it. Thank you, everybody.
Can I just say something? There are now government funded, provincial government funded in Ontario and in Nova Scotia and in Alberta. So the top down can happen.
And I just wanted to follow up that here in DC, you'll hear a little bit more later, but we really want to emphasize that we do it at all levels. So we continue on with that site-by-site grassroots work. We're also going to be working at the health authority level, and Teresa's going to be leading one of the breakouts to just look at that for Fraser. And there's some exciting new things happening with the new collaboration with the Ministry of Health to look at policy. So how can we develop policy that's going to support FLS spread across the province? So I think just having multi-prongs is still a good approach. So if that answers your question, Kirsten. Oh.
I think that's a very important question you asked, and I completely agree with the three answers that you had. And I just want to add one more. Alita had leadership in this area. Early on, 15 years ago, we went to Ottawa. We met with members of Parliament. We met with committees. Amelia has been to PHAC. We've been to the offices of premiers and health ministers. And so her initial initiatives at the highest level, you're referring to, the implication of your question, were not successful. So everything around you, everything you're hearing about today and everything that's being done is building the groundwork. It's now at the director and sometimes deputy minister level. It's at the hospital level. And my own personal belief is that pretty soon it will become compelling. And those who were reluctant to be among the first of one will be in a panic not to be the last.